تحب أبدأ دكتور وليد؟
يعني نصف دقيقة.
نعم.
مساء الخير، أهلا بكم في محاضرة هذا المساء، ويقدمها الأستاذ الدكتور سداد جواد التميمي من كارديف في المملكة المتحدة، وهي بعنوان REM Sleep Behavioral Disorder. تفضل دكتور.
شكرا جزيلا دكتور وليد على دعوتك للحديث عن what we call RBD اللي هو REM Sleep Behavior Disorder. Frankly, I mean, this disorder is not as rare or something that is unusual, but the problem is that we don't focus on it that much. Its importance is the fact that it is related to the prescriptions of antidepressant medication. Sometimes it happens that you see a patient for a while and then they disappear, and it appears that they are under the care of a neurologist. And if you follow up patient for a length of time, you will find sometime that this behavior might appear, especially when you start treating somebody after the age of 40 or 45 for mood disorder. I'll give you an example. There is a gentleman really who presented to myself in the clinic with depression. He's a very fit man, a businessman. He comes with his wife. He's a lovely guy. Then he improved really on antidepressant medication. Continued to follow him up. Every 6 months he comes. Then after 3 to 4 years, he started to see, some masked face. I mean, that's all. This facial expression changed. Then every now and then he complains about, nightmares, behaving oddly sometimes at night, but it happens only every few months. And gradually over the years, unfortunately, Parkinson's disease started to appear, sent into Parkinson's disease clinic. And regrettably, after 7, 8 years, he was diagnosed with Lewy body dementia. This is, just an example of a case you might come across. So what are sleep disorders in ICD-11? You will find that we have insomnia disorders. Then we have sleep-related breathing disorders. We see a lot of them, frankly, in psychiatry because of patients' metabolic syndrome associated with antipsychotic. Then you have hypersomnolence disorders. Now, these you see them sometimes when you do neurology. Then we have circadian rhythm, wake disorders. But the one that are important to us, and I will touch on them today, is what we call the parasomnias. And most of the time we divide them roughly into non-rapid eye movement, sleep arousal, and rapid eye movement, sleep disorder. Then there are the others due to medical conditions, substance-induced, and others. So this is basically how we look at the sleep disorders in ICD-11. Now, what is parasomnias? Parasomnias, para is Latin, is alongside, and somnus is sleep. So alongside sleep. أظن باللغة العربية نترجمها إلى خطل النوم إذا كان ذاك صحيح. How do we define them? They are undesirable behavioral, autonomic nervous system, and experiential event that occur into entry into sleep, any stage in sleep, or during partial or full arousals, may be triggered by psychotropic medication, and this is why it is important to us. And they are common at any age group, and there are some gender differences in them that hopefully we will touch on these later on in the lecture. So what are the parasomnias? How do we divide them? There are so many different classification, but I think the best way of looking at it, the parasomnias, you look at the behavior and experiences, and you look at what is the disorder. The locomotion, the sleepwalking. This is quite common, and frankly, it's so resistant to treatment, frankly. Sometimes you even start to wonder, the patient coming back to clinic and so on, whether it's happening all the time or not. But most of the time it's a benign condition, unlike what you see sometimes in movies, okay? Eating is the second one, and this is what we call a sleep-related eating disorder. People waking up during sleep and go on a binge. Most of the time you find those people do really suffer from bulimia nervosa. Aggression, and this is that one that we will talk about in detail today, and this is what we call the RBD or REM sleep behavioral disorder. Fear, sleep terrors. I think Dr. WALID, talked about them in your page recently, and most of the time they are benign. And of course sex, and this is what we call sexsomnia, okay? But all in all, I mean, these are parasomnias, but the one that is really serious and needs our attention is the RBD. Now, they are frequent. Sleepwalking occurs in 4% of people, night terrors 2%, and RBD is 1%, but actually after the age of 50, the number might increase. Now, why RBD is important and strongly associated with Parkinson's disease and Lewy body dementia. Antidepressant medication and all sedative hypnotics may induce parasomnias. And we have to keep that in mind. We know they are looking at possible genetic markers. There are a few studies that are appearing in the literature appeared in the literature in 2023 and earlier this year. There is a paper appeared. And then we have the treatment approaches for parasomnias. Basically, they are the CBT, medication, and lifestyle changes. Now, I will focus on the RBD now, okay? Now, the definition of RBD is very simple, and it is an all-inclusive definition. Parasomnia involving dream enactment behavior associated with loss of atonia during rapid eye movement sleep. Atonia, most of the time, what happened? Your muscle tone, during REM sleep, okay? Should you lose it, okay? Now, what happened is that with the RBD, that atonia, you lose it. No, you don't become atonic. So how does this happen? We will talk about it. That's basically it. You enact behavior, there is a loss of atonia during rapid eye movement sleep disorder. It's a very simple, all-inclusive definition. So what is the REM atonia? And basically there is a nucleus, okay, in the pons, which we call dorsal precorellus nucleus, okay? Now, we know all the corellus nucleus in psychiatry, but there is another one, precorellus, which carries over glutamate neurons. And there are ventromedial inhibitory neurons. For one reason or another, these REM atonia is occurs because of the activity of that particular nucleus. Now, suddenly it happens, something goes wrong with your RNA, messages being sent, genetic inactivation of that nucleus and the medullary inhibitory neuron. And this is when we start to develop gradually the RBD. So basically, this is what happened, is that something goes wrong with your DNA, RNA send message, and suddenly that nucleus, become inactive. And this is why you see this illness, when you find it occurs, like, for example, in the first year, maybe once or twice. Then it occurs every 3 months, every month. Gradually, you find the deterioration and the nucleus will die. So how do we diagnose it? Now, one thing about the diagnosis, you cannot really make a clinical diagnosis of RBD. Yes, you can suspect it, but you need to do sleep studies. And the sleep studies, you cannot do the ambulatory one. You can't just really put the electrodes and so on and send the guy home and ask him to come back and look at his EEG and EOG. No, he has to go into a sleep clinic to monitor. Now, so the diagnosis is, these are the criteria. It's a repeated episode of sleep-related behavior, include vocalization and or complex motor behaviors. Documenting behaviors by the polysomnography during REM sleep or based on a clinical history. The recordings that demonstrate REM sleep without atonia via the submental or limb leads. Most of the time you put the leads here, these are the most important one. And you look suddenly that usually you find that during sleep is flat, okay? But that during RBD, you could see that it is quite active. And behaviors are not better explained by another sleep disorder, mental disorder, medication, substance use, or epilepsy. Now, although people stress epilepsy, but to be honest with you, most of the time nocturnal seizures and juvenile myoclonic epilepsy, you don't see it in the age group of the patients with RBD. Right? And I get surprised sometimes people keep on investigating nocturnal epilepsy in those people, despite the fact that it is, nocturnal episodes of epilepsy are quite rare after the age of 20, 25. Now, the diagnosis as well, as we said, the disturbance cannot be explained by another sleep disorder, another mental disorder, medication, and substance use. And I will touch on these in details in a while, okay? So what are the causes? Now, sometimes some people divide it very simply as idiopathic or associated with a neurodegenerative disorder, okay? More recent classification, of the causes is a little bit more detail. First of all, you have the most common is the secondary to medical condition. Lewy body dementia, the worst of the dementias, as we know. Parkinson's disease, olivopontocerebellar degeneration, that's quite rare. Multiple system atrophy. This is also quite rare. Most of the time, RBD will occur after the onset of multiple system atrophy, and of course, Shy-Drager syndrome. There is the idiopathic, but most of the time, the idiopathic usually will mature sooner or later into Lewy body dementia or Parkinson's disease. There is the drug-induced, we will talk about it. And then there is the RBD with narcolepsy. When you see patients with narcolepsy, also you follow them up, you will find that you sometime, the age of 25, 30, they start to have these. But it is distinct phenotype, it's different. You find earlier age of onset, their age is in their third, fourth decade. Less violent behaviors, not like the RBD. It is associated with orexin deficiency, and it is equal sex distribution. Although people say that in recent reviews, but frankly, if you look at the RBD in general, the fact that it is more common in women, in men than in women, might be wrong. I mean, there is a study from Japan, an epidemiological study, who demonstrated no, it is equally common. But what's the problem is that the people who are referred to the sleepy clinic are usually men. Are men are more violent, not like women. There is another one, which we call acute RBD, which is associated with withdrawal from alcohol, antidepressant, sedatives, and drug intoxication. Now, what are the behaviors then you notice during the RBD? I said, I mean, the typical example will come is that the patient will fall asleep after 90 minutes, he entered to REM sleep, and you will start to see some of these behaviors. Sometimes these occur after 4-6 hours, you go into another cycle of REM sleep. Typically, their eyes remain closed, right? So they are not really fully awake, their eyes remains closed. But don't forget, one of the reasons for that, if you think about it, is that there is a loss of atonia, okay? Sometimes some of them minimal, their behavior, limb twitching, jerking, more complex, waving, grabbing, reaching, searching, punching or kicking, vocalization, then you have talking, yelling, laughing. And there isn't, a stereotype for each patient. No, you will have a mixture of these spectrum of behaviors. Important to know that there are no sexual behaviors in RBD, okay? Because sometimes some people say, oh, there is something happened like that. This has nothing to do with RBD. And sexopnia, frankly, is a non-REM sleep disorder. And it's always a sexual behavior without a dreaming. And sometimes you wonder if it is even without a sleep. Okay. Now, what are the dream alterations? So patient will have a dream. They usually recall them, by the way. Okay. They usually recall the dream. They are vivid and intense. I said occur after 90 minutes. They are unpleasant. They are full of action and surprisingly recalled in more than 50% of the patient. They will tell you what is the dream. Now, typically their dream, they even feel threatened by unfamiliar people, animals or insects. And in the dreamer rarely is the aggressor, okay? So he is the one, in the dream, he's the victim. But unfortunately, his behavior sometimes is that of an aggressor during the RBD behavior, okay? So what is the differential diagnosis? Nowadays, of course, there is the non-REM sleep. All of you, they come across them. Sleep terror, confusion arousal, sleepwalking. They are benign condition. All what you need to do sometimes reassure the patient, okay? But there is now something new appearing, okay? As you know, the concept of trauma is infiltrating all specialties in psychiatry. Now, this is what we call a trauma-associated sleep disorder. They call it now, it's a parasomnia. Usually it is in younger males with traumatic experiences. It's not females. Usually see more in males. There is temporal onset of disturbing nocturnal behaviors and nightmare. Not all of them suffer from post-traumatic disorder, okay? Most of the time they don't. There is objective findings include REM without atonia, okay? And disruptive nocturnal behavior captured in the lab are rare, okay? So that is the one that you started to appear, there's a case reports here and there. Some people start to think about PTSD, dreams or RBD dreams. PTSD dreams usually involve traumatic event. Specific people and events occur in reality as well. In my experience, the best indicator of a dream is in PTSD. They are primary, memories, color, sounds, something like that. While in RBD, it is the other way down. You know, they are attacked or threatened, unfamiliar people, and anomalous scenarios. I mean, they don't make sense sometimes. But their behavior can potentially be lethal, okay? Why? Choking. They choke their bed partner. Punching the bed partner. They jump through a window. There has been a case report here and there. Diving from the bed, resulting in head injuries. All these are based on case reports in the literature. So how prevalent it is. I said, people say it's equally common in males and females, in my opinion. Although when you read some papers, they say, no, it is more common in males than females. But there is a Swiss study and there is a Japanese studies who demonstrated that they are roughly equal. More males are referred to the sleep clinics. Often begins after the age of 50. And really, if you think about the prevalence, it's similar to that of schizophrenia, and that's of 1%. There are facts, then we know that associated with narcolepsy and cataplexy, and we've said this is special phenotype. Another fact can be induced by SSRIs, so keep that in mind. And polysomnias overlap, you know, disorders RBD and non-RBD. So sometimes you will find a mixture of RBD and non-REM sleep behavior disorder. So keep that in mind, okay? The fact that people present sometimes with sleep terror and sometimes with RBD, there is an overlap with these, okay? Now, RBD and Parkinson's disease or Lewy body dementia, conversion rate of idiopathic RBD to PD or LBD is more than 80% after 10 years. This is why I say there isn't really something idiopathic. Unfortunately, it is always a sign that there is some degree of a progressive degenerative disorder taking place. So what do you say? I mean, people, you know, sometimes after the age of 50, people complain of nightmares. They come to your clinic. There is a screening question, which is agreed on, you know, by a number of organizations. Simply ask the patient, have you ever been told or suspected yourself that you seem to act out your dreams while asleep? For example, punching, flailing your arms in the air, making running movements. It's a very, very simple question. I think you can easily translate it to any language. Okay. If the answer is yes, you have to take the case seriously and start doing some work on the management of a suspected RBD in this case. So how do we evaluate that? First of all, systematic sleep evaluation. You do a proper mental state, ask the patient about the sleep pattern, any change in sleep behavior, and so on, number of hours slept, what do they do before they go to bed, what time do they wake up, and so on. Take a clinical history, and then you arrange polysomnography. But I said, do not arrange the ambulatory one at home. No, try and get in contact with the sleep clinic and try and book your patient an appointment. Usually sleepy clinic, there were plenty of them, to be honest with you, 15 years ago. But nowadays you find them only in teaching hospitals. And they have plenty of space. So if you give them a ring, you can always get an appointment quite quickly. Now, how do we manage it then? The most important thing is you protect the bedside environment. So mitigating fall risk, you lower the bed closer to the floor, okay? Safeguarding any firearms, knives, and other weapons in the bedroom. Cushioning, you know, all right, moving the furniture around, placing patient in restraining clothes or sleeping bags. They do that sometimes in patient in advanced stages. Separating the sleeping partner from the patient to reduce the risk of injury. And frankly, this is usually the first step you take, okay? If they sleep in the same bed, ask them to sleep in separate bed If anything happened, they have to sleep in different bedrooms. Make sure all the windows are closed, by the way. Now the medication. Now, it responds well to treatment. It doesn't, cure the illness, but you can control the episode quite significantly to around 80%. The drug of choice, there is general agreement, is the clonazepam, 0.25 milligram daily. You start, this is smallest dose. Frankly, I start 1.25. Why is that? In my experience in epilepsy, clonazepam sometimes may induce, a catastrophic reaction following the first dose. People might suddenly you give them 0.25, 0.5, they fall asleep for 3 days. Something you notice only with clonazepam and primidone, which is also another anti-epileptic drug related to phenobarbital. So start with 0.125, test dose, and 0.25, and you can gradually increase the dose up to 4 milligrams. It's highly effective. Now, why do we choose the clonazepam? Clonazepam is a longer acting. Its half-life is 72 hours. Withdrawal symptoms are very unlikely. Some people cannot tolerate that. They have falls during the day, they feel sleepy. Then you can start prescribing melatonin. You start with the 3 milligram and gradually increase the dose to 15 milligram. Sometimes you can combine the two. But then RBD with Parkinson's disease, they don't really, sometimes they don't always respond to melatonin and clonazepam. So there is a drug, I think you all know about it, which is Ramelition, which is a selective melatonin 1 and 2 receptor agonist. It is not as effective as clonazepam, but sometimes you can also add it to older adults, who do not have Parkinson's disease, okay? They cannot tolerate clonazepam or melatonin are ineffective. You can add Ramelition or Tion, okay? Now, the last bit of the lecture, we'll talk about medication-induced RBD because it's very important to us, okay? And something we have to keep in mind. In all adults, we prescribe antipsychotic, antidepressant. The general principle is that all antidepressant can induce RBD, okay? SSRIs and venlafaxine are top of the list, okay? Some people say, oh, mirtazapine is safe. No, it is not, because we use it a lot for sleep. There has been case report with it. The only two drugs that are the exception are bupropion and trazodone, okay? Now, trazodone, there are no case reports of trazodone causing RBD. I think one of the reasons probably is that because it's not widely prescribed as an antidepressant. People use it more nowadays, especially in the States, as a hypnotic. But trazodone is a tetracyclic antidepressant, very effective. It's also a very safe drug. It's a very safe drug in people who have heart attack, okay, who have cardiovascular problems. Now, why use bupropion? It's a dopaminergic and noradrenergic agonist. If anybody you suspect of having RBD or complain too much of having nightmares, you suspect there might be a case, try and think of bupropion as a first choice in depression. I know it is not the #1 drug for many, many psychiatrists, including myself. Other medication inducing RBD, quetiapine among the antipsychotic. This is why you see quetiapine, a lot of people prescribe it as a hypnotic at night, isn't it, for older adult. But remember, it is the one most commonly associated with RBD, okay? Beta blockers, sertraline, anticholinergic, and rivastigmine. Now, with the medication-induced parasomnia, the principle is that the medication-induced parasomnia is improved when medication is stopped. But with the SSRI, depending on their half-life, you will find that the will take longer. Now, this is a very, very controversial statement that you see it a lot in the literature nowadays, is that the individual taking SSRI after the age of 50 may be at an increased risk of developing RBD and Parkinson's disease with increasing age. Okay, it's a very controversial statement, but a lot of people think, well, people are at risk of having RBD. Nobody has said this, what happened to these nuclei in the brain? Is it because of the SSRI? We don't know. So consider switching antidepressant if you can. Sometimes some patients, of course, will refuse to come off the antidepressant, as you know in practice. Then you have to treat the RBD alongside the depression. These are the references that are used today in the lecture, okay? And you can have a look at them. They are very interesting. And thank you very much indeed for asking me to talk to you today. Thank you.
شكرا جزيلا دكتور سداد على هذه المحاضرة الرائعة والمعلومات القيمة جدا على في مجال قل الحديث عنه صراحة. يعني من موضوع السليب عموما والسليب behavioral problem يعني تراه أحيانا وكأنه خرج عن مش ضمن النطاق هذا بسبب معاناة، لأنه ما أراه أنا على أرض الواقع كثير من المرضى اللي عندهم هذه المشكلة يعطوا SSRI وتزيد الحالة ويستغرب الطبيب، يعني كيف تزيد؟ مش لازم. فمع الأسف يعني لابد من نشر ثقافة جيدة بين الأطباء إنه هذا الأمر مش يعني عشوائي العلاج، هناك مرجعية وهناك أساليب صحيحة وأخاطئ. تمام، أترك المجال لمن له سؤال من الحضور، تفضل دكتور أمين.
مرحبا. شكرا دكتور سداد على المحاضرة القيمة. عندي بعض الأسئلة لو سمحت.
نعم.
بالنسبة لموضوع restless legs والأكاثيزيا, which is most likely related to the adverse effects of the antipsychotic medication. Can you please make any comment about the treatment in situations like this? The other thing, as you know, in the past, they used to use sleep as a treatment for schizophrenia, like induced coma, for example, with insulin. Nowadays, we are talking about the sleep problem and RBD as induced by the treatment of schizophrenia. So what's your opinion about the induced sleep problem or deprivation of sleep as a traumatic experience to individuals? Like, for example, openly, I can say that the enemy in West Bank or in Gaza, there is no doubt that they are inducing sleep deprivation to the usual ordinary public, mainly to make chaos within the environment. So this kind of induced deprivation of sleep by making noises, for example, or making trouble around the area, what are the consequences of it? And the other thing you mentioned about melatonin. Am I right of saying that it's not licensed for adult? It might be given to children, but not for adult age.
Oh, no, it is licensed for adults. No, melatonin, actually, it only it's in the United Kingdom, you don't see it. It is sold in every pharmacy over the counter in Europe and the United States. And no, even in the UK, you can get it. I mean, for example, I had a patient with Wilson disease, so I give 15 milligram of it. You can get it from the pharmacy on a prescription here. But
Available, in fact, in Jordan, available as supplement without
yeah,
prescription, not as medication.
but in the UK it is not available. It's unique in that.
My understanding, Dr. Sudad, if you allow me, there is a hepatotoxic effect of the melatonin in adults.
Oh,
There is the risk there. And this is why, for example, in our trust, we don't prescribe it for adults.
What about circadian? Don't you prescribe it?
Circadian is the same as melatonin.
Yeah, it is melatonin, but it is quite a safe drug, you know?
Yeah. Why I'm saying this, because very often what's happening that children, when they are with CAMs,
they don't give.
They take melatonin. But when they come to us, we say we face real problem of prescribing it to them.
Yeah, so frankly, you find, sometimes, these prescribing practices, depending on the pharmacist and so on.
Could be.
Coming back to your question, I mean, sometimes, of course, one of the things that one can look at, hopefully in a future lecture, is to look at the movement disorders that are associated with antipsychotic medication. By the way, there is some kind of a relationship between the parasomnias, what happened, the mechanism of them, and also what happened when we prescribe antipsychotic, when we started to see akathisia, and more specifically, the restless leg syndrome, or sometimes we refer to it as RLS. Now, the RLS sometimes can occur on its own without using antipsychotic. And I think you have to accept that the first task will be you start to think, well, I am giving a medication that is saturating the receptor. I have to reduce and vacate some of these receptors. You start to do that. Now, in my experience, there are so many trials of medication you can give. There is people using clonazepam, sometimes even people use primidone. But hopefully, if Dr. WALID will allow me, I will go into detail about these movement disorders, because I find this is one of my interest in neuropsychiatry. Now, sleep deprivation. Sleep deprivation, as what's happening in Palestine and Gaza, I totally agree with you. And we have to think of any one of us. Put it this way, we spend at least 1/3 of our life asleep, okay? Why do we do that? So that we let our cells, our, RNA do the cleaning, okay? You get rid of all these toxic metabolites we accumulate. This is the function of sleep. It's a cleaning job, okay? It cleans all the rubbish that we created during the day. Now, when you deprive people of sleep, you don't even affect them mentally. You affect them mentally, psychologically, and physically, okay?
No.
Because all these free radicals are accumulating. And this is something one people have to keep in mind. Sleep is not really for you to be more focused. And depriving people of sleep because of noise or thought, it's a criminal act, in my opinion. Okay. Why? Because you said the free radical over. Who will do the cleaning? Just like you leave an office, you sleep. It's just like think you leave an office, a cleaner will come and clean the office for you. The following day, you come and see it's refreshed. This is the same thing. What happens in the body. This is why sleep disorders are very, very important.
Thank you.
Thank you.
دكتورة صفية تسأل, is there a need to make a follow-up for patients with REM behavior disorder for Parkinson's disease? And if there is a medication as prophylaxis?
No, yes, I mean, you have to follow them up. When they do, I mean, most of the time, Parkinson's disease with RBD, when they start to have more and more RBD, I think it depends on who is looking after them. All right. Most of the time, the neurologist might really ask the psychiatrist to focus on them, especially older age, uh, older adult psychiatrists to look after them at the end. In the beginning, find the neurology will be interested in diagnosing, doing sleep studies, showing you these wonderful graphs and so on. But most of the time you end up, I mean, you have to follow them up closely. A lot of them with the advance of Parkinson's disease, you keep an eye on the appearance of Lewy body dementia, because that's really something that worries everybody. And all the complication, Lewy body dementia, the hallucination and so on. But try and treat the RBD as early as possible to give a better quality of life for longer period of time.
دكتور علي كامل، أي تعليقات؟ تمام. In that case شكرا جزيلا دكتور سداد على هذه المحاضرة القيمة والمفيدة، واللي كانت to the point، وأعتقد بأن الجميع استفاد منها. شكرا جزيلا، نلقاكم في محاضرة قادمة إن شاء الله.
شكرا جزيلا.
شكرا جزيلا.
بارك الله فيكم.